Next up, we have Mark Terry, and if you've never heard Mark Terry talk about PK, listen up.
Thanks very much. It's actually a real pleasure to be on the podium here in my hometown. I grew up here in San Francisco, not very far from this convention center, so it's great to be here with you. Also, I thought all the blue bloods were in the Pacific Heights here, not in the frogs. So we're going to talk about when I still turn to doing PKs, and yes, we do PKs. My financial disclosures have nothing to do with this talk. So there are obvious clinical settings for penetrating keratoplasty. If you've got corneal edema and a central stromal ulceration and or scarring, then you want to do a full thickness treatment for the full thickness disease. Now the exception to that is if you have a haze or a scar that's simply from edema, in which case you don't want to do a PK, and I'll show that in a second. If you've got infectious keratitis, something like this, where you have a generalized endothelial decompensation and stromal loss and possible perforation, a PK can be used as a tectonic graft, and sometimes you get lucky and that will stay clear and you'll end up having some vision as well. So these are pretty obvious clinical settings for PK. Now what about if you have a failed prior penetrating keratoplasty because they've had endothelial cell loss, and they've got edema, and they also have high astigmatism, and they're contact lens intolerant? Well, that's when you should do a PK on those folks. But I always have a rule of thumb that I use with penetrating keratoplasty eyes or keratoconus eyes, is that if the patient was happy with the penetrating keratoplasty before the edema set in, then you should do an EK under PK and return them to that happy state. If the patient was unhappy with the PK before the edema, then just do a repeat PK. Here's an example where you have advanced Fuchs dystrophy and you've got all that scarring there, and my gosh, you're not going to be able to see very well if you leave that scar there. But when you do the OCT and preoperatively, you'll see that that scar tissue is just simply epithelial redundancy and basement membrane. And when you go down and start at the area not where the scar is and start cutting down, get down Bowman's layer, you can simply peel these off, leaving you with a beautifully clear central cornea. And 6 weeks after the DMEC surgery for the Fuchs dystrophy, the patient was 20/20. Now, there's clinical settings where PK is just one option. If you've got keratoconus with confluent Fuchs dystrophy, and you can have confluent guttata with Fuchs dystrophy and keratoconus at the same time, then I would say do a penetrating keratoplasty. It's full thickness disease, do full thickness surgery. Now, what if you've got keratoconus and non-confluent Fuchs guttata? Well, I would do a DALK in that case, not a PK, because although there is disease of the endothelium is not so bad off that they won't have a good result with a DALK. And what if you have Fuchs, significant Fuchs, with mild to moderate keratoconus? Do you do a PK or an EK? Well, I would do an EK because sometimes you can clear the edema and actually improve the keratoconus. So here's an example of a case that I did almost 12 years ago, and this patient had moderate Fuchs with mild keratoconus, and preoperatively the best spectacle corrected visual acuity was 20/40 with 3 diopters of irregular astigmatism. 1 year after the DALK surgery, the patient's best spectacle corrected visual acuity was 20/25, and their astigmatism went down by about a diopter and actually improved in its regularity. Now there's other clinical settings where PK is just one option. What if you've got an eye that's got severe scarring of the stroma, but a healthy endothelium, but you've got a lot of extensive anterior segment work you've got to do, whether it be a sublux cataract, extensive iridoplasty, suturing an eye wall, etc. Well, certainly if you do a PK, it makes it a lot easier. You got an open sky, you got a great view. But let me suggest another option. Why don't you just do an 8mm trephination like you're going to do a cut-down DALK, not a big bubble, cut down to 90%. Now you remove that 90% of the stroma, leaving that posterior 10% left. Then you take a soft contact lens, and you trephinate the soft contact lens to a 7.5 or 7.75. And you put that in that well you've created with your trephination on the donor, or the recipient, and now you have a beautiful view because the contact lens, the soft contact lens in the bottom of your cut-down DALK gives you a view to then do the anterior segment work you need to do with a closed chamber, and you've retained that healthy endothelium. So what about a patient that also is a possible option? They've had a successful EK years ago, but now, 5 years after their DALK or DMEC, they have a stromal ulcer or scar in the setting of that successful EK. Well, you can certainly do a PK because it's full thickness, and that will get rid of that remaining endothelium, but that's a healthy endothelium, which has already been accepted by your recipient. I would prefer to do a cut-down DALK and preserve that accepted endothelium. Now, this is another controversial setting for penetrating keratoplasty. What about fungal infections of the interface after DALK or EK? It's my strong personal opinion that you should go quickly to a penetrating keratoplasty. The interface infections are sequestered from your medical treatment. We know that most of these eyes are going to go on after the medical treatment to a surgical solution. And you risk fungal endophthalmitis if your medical therapy fails. This is an example of a case that was referred to my colleagues Hide Yogigawa and Akira Kobayashi in Japan, where they were sent a patient that had this going on after the sake. They went quickly to a penetrating keratoplasty, and 17 days later, they now have a cure, and the patient's vision is 20/40. I'd like to present one more thing that I think is kind of interesting, and I'm hopeful you'll take a little bit of this home. What if you've got ulcerations and infections that are so extensive that they require a 10 millimeter, 11 millimeter, 12 millimeter transplant? I do not recommend a penetrating keratoplasty. I recommend a hybrid graft. So here's an example of an eye that doesn't look so good. It's got ulcerations everywhere. It's been treated with medically for the suppurative keratitis. But here's a schematic here. You can see it's ulcerations everywhere, including centrally and in the periphery, all the way to the limbus. If you do a full thickness penetrating keratoplasty, here's what happens. You'll cut that out, get rid of all that disease. Then you take your full thickness transplant, you put it in place, and immediately those angles are obliterated. The iris is going to go up, stick to your graft. You're going to end up losing your endothelium. You're going to end up putting a tube in this eye. All kinds of terrible things happen when you obliterate the angle. So what's a hybrid transplant? It's not the transplant that's hybrid, it's actually the recipient bed that's hybrid. So if you go down and you cut down at a 12 millimeter, you're in sclera all the way around, and you cut down 90% and leave just 50 to 100 microns of residual stromal tissue, you can carry this as far as you possibly can. And then when you get to the necrotic tissue in the center, then you can trephinate an 8 millimeter area within this lamellar bed that is at 12 millimeters. And then when you take your transplant, which has full endothelial coverage, and you place it on top of this residual stromal bed, your angles will remain open. Your iris will stay back because the edge over here is too far away. The edges will be fine, and your iris will be fine, and your angles are open. So that's what we did in that case I showed you. Terrible looking cornea. We created this flange in the periphery, this bed, lamellar bed in the far periphery, and a central opening. And then we placed our 13 millimeter graft and sutured in the iris 9/0 nylon. And we went from this to this after 3 months. The advantage of this is the angle's wide open. The pressure is 16 on no meds. The vision's great with no glasses because the sutures are so far out there that they don't cause compressive astigmatism. There's other cases I could show you, but time limits, and I've got 2 seconds. We always need to be able to do a full thickness PK for full thickness disease. Complex cases should be evaluated independently for the risk-benefit ratio of doing selective tissue replacement versus full thickness replacement. In my opinion, early PK should be considered for every case of fungal interface infections due to the risk of fungal endophthalmitis, and very large transplants that encompass the limbus should be a hybrid and not a PK. Well, I'd like to thank my son and my illustrator, Charlie Terry, as well as my son Nicholas and Cindy for allowing me to be here. And I thank all of you for your very kind attention, and welcome to San Francisco.
Thank you, Mark.